in-person versus video preoperative visit, a randomized clinical trial by Dr. Braxton.
With in-person presentation. Welcome.
I'm going to have to read my notes on my computer.
I have two presentations. I have 2021 and then MPVV MIGS. You know which
The
one?
first one. Perfect. That is it. Excellent. Well, good morning, and thank you again for the opportunity to present our work. Does this move it forward?
The on switch is on the side.
Perfect. Thanks. Excellent. Okay.
Dr. Braxton, would you mind introducing yourself? And where you're
Yes,
from?
I'm so sorry. I'm Dr. Elizabeth Braxton. I'm recently at Carolinas Medical Center at Atrium in Charlotte. So preoperative patient education is an important aspect in preparing patients for surgery, and it's traditionally performed as an in-person visit. Patient preparedness plays a role in improved postoperative satisfaction in FPMRS patients. However, the in-person visit results in increased travel time and financial burden. Telehealth visits have been shown to be safe and convenient for patients in postoperative care of surgical specialties. And recently published data supports the use of telephone preoperative counseling in preparing patients for FPMRS surgery. However, at the time of our study initiation in 2019, there was no published data evaluating telehealth for preoperative counseling in the FPMRS population. The primary aim of this study was to determine if preoperative video visits are non-inferior to in-person visits in preparing women for pelvic reconstructive surgery as measured by the preoperative preparedness questionnaire. Secondary aims of this study were to compare patient satisfaction, patient convenience, visit duration, total in-person visits, and office contacts in the perioperative period, as well as patient round-trip travel time and distance. Inclusion and exclusion criteria were as follows. Eligible women were approached after their surgical consultation. Verbal consent was obtained and they were randomized 1-to-1. Women completed the PPQ after the pre-op visit. They completed the preoperative portion of the SCAP survey at the 2-week post-op visit. And then additional secondary outcomes were captured from the EMR after the 6-week post-op visit. Standard counseling with an FPMRS fellow was completed with their respective visit type. Patients completed the PPQ at the end of the visit on paper in the in-office group and via an electronic link for the video group. The main difference in visit timing between groups is the office visit ended when the fellow exited the room to allow time to complete the PPQ prior to checkout versus completing it on their own time in the video group. The patient preparedness questionnaire is shown here. The answers are individually scored on a 6-point Likert scale ranging from strongly disagree to strongly agree. Cumulative scores were then obtained with higher scores corresponding to increased preparedness with a total raw score range of 11 to 66 points. Patients returned for a 2-week post-op visit, following which they completed the preoperative subsection of the SCAP survey. And then after the 6-week post-op visit, the EMR was reviewed for total office contacts, including scheduled and add-on visits, as well as patient or nurse-initiated phone calls. Round-trip travel mileage and travel time from the patient's address on file was calculated using a secure map analyst platform. This study was powered to detect a pre-specified non-inferiority margin of 9 points in preparedness scores. This non-inferiority margin was chosen based upon clinical considerations of clinical importance as well as statistical tradition of at least reserving 80% of active control effect. A sample size of 45 in each arm were calculated to achieve a power of 0.8 with significance of 2.5%. Considering a 30% dropout rate, we required 59 patients in each group for a total of 118 patients. Recruitment began in July of 2019 and went through December of 2020. There was, of course, a brief hold on recruitment due to the COVID-19 pandemic. Once we were allowed to resume elective office visits, we submitted a protocol amendment allowing for that 2-week postoperative visit to be held virtually. The full consort flow diagram is displayed here with key points noted in bold. 118 women were randomized with 59 in each group. 2 women in the video group were actually not able to complete their visit due to technologic difficulties and subsequently had an in-person visit. In the per protocol analysis, 53 women were analyzed in the in-person group and 48 were analyzed in the video group. Demographic characteristics were similar between groups. There was a slightly higher BMI in the video group and slightly more women in the in-person group had previously used text messaging for healthcare delivery. There were no differences in surgical characteristics and approximately 85% of patients went home on the day of surgery. In both the intention to treat analysis and the per protocol analysis, video visits were non-inferior to the in-person visit based on preoperative preparedness scores. More women in the video visit group reported their visit as convenient, but there was no difference in patient satisfaction. When asked what type of visit they would prefer in the future, nearly half of the in-person group would prefer a virtual visit, and nearly all of the video visit group preferred a video visit. The video group spent significantly less time in contact with our office staff at the pre-op visit and had fewer total scheduled in-person visits. There was no difference between groups in total post-op add-on visits or number of post-operative patient or nurse-initiated phone calls. As expected, round-trip travel distance in time for the preoperative visit was less for the virtual group. So, in conclusion, in this randomized controlled trial of preoperative counseling, we found that video visits are non-inferior to in-person visits in preparing patients for surgery. Limitations of this study include selection bias inherent in the enrollment process. Barriers to video visits were not captured. Additionally, the patient preparedness questionnaire is not a validated instrument. However, this has been used in several other studies within an FPMRS population and was the most applicable instrument for addressing our goals. And also, I do believe that most recently at AAGS, a group did look at validating that instrument. So I'm sure we'll be hearing more about that in the published literature soon. Lastly, the study halted during the COVID-19 pandemic with subsequent protocol amendments required when enrollment resumed. The strength of the study include its randomized controlled trial design. We were able to continue our study after COVID-19. Elective visit restrictions were lifted, which allowed us to reach our intended enrollment and reach statistical power. Additionally, there was concordance between the intention to treat analysis and per protocol analysis in our primary outcome and most secondary outcomes. The only differing result in the per protocol analysis was composite SCAP scores, which were not statistically significant between groups, or statistically different between groups, excuse me. And finally, this study, it's timely. As the COVID-19 pandemic highlighted the utility of telehealth visits, we all have experienced it. In conclusion, video visits are non-inferior to standard in-person preoperative counseling visits in preparing women for pelvic reconstructive surgery. A video preoperative counseling visit decreases patient visit duration, travel time, and travel distance. This study supports the use of video visits for preoperative counseling prior to pelvic reconstructive surgery, and we actually have changed our office practice in light of these results. I'd like to acknowledge my co-investigators. Without all of these people, this study would not have been completed. Thank you so much for your time.
Thank you, Dr. Braxton.
Thanks very much. Interesting topic, because more we're coming to that, even intercontinental consultations and so on, so that's very interesting. So it's our pleasure now to invite Dr. A. Cope to talk on intraureteral ICG in benign gynecological surgery.